And we're back. All right. When I kind of like this, and I know you've had it before, but I want to give you my type of presentation on cranial nerves because I think they're really important. And then we'll carry on and we'll finish the peripheral nerves, which are a little less complex than the cranial nerves. But cranial nerves are, I mean, there's so much control of of our bodies that emanate from that of such significance that I really think it has to be covered in a fairly elaborate way rather than just saying memorize the names of the nerves. So that that's where I'm coming from with regard to that. So you'll see it here, and hopefully this won't been in bad terms so far for technology. So the cranial nerves are just that 12 pairs, one right, one left, obviously, and they come from. There's only two that are in the uppermost areas. Those are the first two. Those are the sensory nerves we've just been talking about, the olfactory nerve, and the optic nerve. Purely sensory, the only two that are in that. So as you can see, not most, they're all mixed. I mean, again, that's the PowerPoint trying to be clever. And they're named from rostral to caudal, which just means top to bottom, superior to inferior. And everybody in the world has a mnemonic for that. And you can look them up, you can make up your own. It's not hard. They use Roman numerals. You can write 1, 2, 3 on a quiz I don't care. You don't have to familiarize yourself with the Roman numeral thing. Again, if you're not comfortable with that, names work, regular numbers work, and Roman numerals work on any type of thing. So even on an exam, I would put I probably put the like say 3 and then Roman numeral 3 next to it. That's just the way I do it. So to me, it's like a rite of passage. That's part of it, and you do it all over again. This is a classic view that you see. My guess is you would see this view on a laboratory practical if we're doing a practical with image identification. It's not so easy to tell down here. The first 6 are fairly easy, and very often, and if you noted any of them, you should have noted at least the top 2 on the brain dissection. The olfactory nerve, which is in the undersurface of the frontal lobe and adherent to it, very distinctive. And even if you got one that had a lot of the stuff removed, the remnant of the optic nerve would certainly have been there, some aspect of the chiasm. Okay, and then the opening for the pituitary, and immediately below that, and it's larger than you think. Not so much to scale here. This is the oculomotor nerve, and then we get to the trochlear, and this is the trigeminal, and then every so often, and I've done hundreds of those sheep brain dissections with students over the last 20 years. Every so often, I'll even find an abducens. After that, there's just little threads, and it's a little hard to ascertain that are there. So I'll go through the relevance of them, and the way I always framed it, this is what I think I told you what they used to do on the sideline. This is or on the field. This is the neurological survey. If you come upon somebody, so let's say for those of you and you're about to do a procedure on somebody, and all of a sudden they fall down. I mean, eh, you've got they look like they're cogent and everything, But if you're dealing with an elderly person who falls suddenly, it's probably a good idea to do at least some type of neurological survey quickly to see if everything's intact before you start lifting them up or moving their head, because you could create more problems than work. Okay, I've seen that too many times. You know, for you, maybe not for me. Falling down, you're going to get right up. Okay? If you don't, then it's good. Then it's very suspicious. You get someone my age, it's like, I wonder what's going on up here. So that's part of it. This is a really good chart because it tells you, sometimes erroneously, purely sensory, everything else is mixed. Doesn't matter what they say. Okay, so ignore any of that type of stuff. If they're saying no over here, if you're talking about sensory and motor, understand they all have some degree of sensory function. And I'll reiterate the point. And I talked about it early. Proprioceptors. I mean, if they're saying like with the oculomotor nerve, which controls extra ocular movements, moving your eye. If your eyes are pointing up or pointing down. You only know that if they're sensory. That's what proprioceptors do. They tell you where any part of you is in a position at any given time. When people become unaware of that, That's significant. And where you will see this the most by far is in diabetics, particularly as they're older, because their sensorium is sort of the global term used for that gets affected really easily. You even see them when they walk the times. They got to look to where they put their feet. It has to do with not being able to feel the bottoms of their feet. I mean, I've taken bone out of a diabetic without anesthesia. So moving on. What's interesting about this is this. PS stands for parasympathetic. In this case, you read that all as glands that are there. So the parasympathetics are there, all, and particularly the vagus. Surely the most important. The other ones are a little bit more limited. One we've already talked about, which is the third, with the pupillary light reflex and the accommodation. That all is mediated through the oculomotor nerve. So it's just sort of, and as I'll scroll down, sort of, as I'm kind of doing this scrolling down through the nerves, you'll see. And I'll make some comments about some of the conditions, and you will see some of these conditions. If you're involved in a clinical field, you're going to see people you're going to see people with a cross eye. You're going to see people who have a thing called Bell's palsy. It's much more common than you think. Okay, they are, and so there's a certain degree of relevance that's associated with this, I think. So smell is easy because we very rarely test it. If you do a thorough neurological survey, you do test it. It's easy to test anything with a distinctive odor. That's what smelling salts were about. And maybe I told you, because I never remember, years ago when I had in any of my offices, every room that we saw patients in, we had two things on the wall, okay, additional to whatever else might be on the wall. That was a little ampule of smelling salts with a piece of tape, so we always knew it was handy, and a padded tongue depressor in case somebody started to have a seizure. That way, I don't know if that's still the rules or not, but that was the rules back then. I had one of the earliest offices in where I was practicing that was certified by HMO, and in this case, it was UPMC. HMO had come up and they had to inspect your office and make sure everything was the way it was supposed to be. I mean, it took us months to get that ready for inspection. So there's a lot that's involved in that type of stuff. And you'll become familiar with that, and maybe you are doing so now in a clinical sense, that are there. And yeah, what's interesting about this sensory, it's the only one that goes right into what they call the forebrain, the cerebral cortex. So why does smelling salts work? It's a direct stimulus. Boom, open your eyes. And the only way you can have somebody follow their fingers is if they're awake. You know, they're comatose. Doing that, not going to work. I've tried. That was a joke. I know. Just be like my wife. Ignore me. Oh, did you try to say something that was funny? No, I wouldn't have been successful. So it runs from the nasal mucosa, okay, where it starts, the sensor, all the way to bulbs are the ones that were on the undersurface of the forebrain. It penetrates through the ethmoid bone, that's the cribriform foramina. So, I mean, if somebody gets a shot to the nose, a ball hits there, they get punched in the nose, it's one of the things you look for, okay, because it would tell you that that's an area that could signify a loss of smell from, let's say, a traumatic incident or even a stroke along those types of lines that are there. And so you typically use, and they give you a little idea, fractures, okay, damage, lesion, something that shouldn't be there to the olfactory fibers, partial loss, you test it with, again, very aromatic. We typically, smelling salts are generally spirits of ammonia. You can use oil of cloves, vanilla, you can have vanilla extract. I want to do that. Not the imitation stuff. I only get the real stuff. My daughter-in-law, who used to bake professionally, when they lived in San Diego, they got this, oh God, this Mexican vanilla extract. It was unbelievably good. I mean, for baking, it was great. They don't even ship it. They had it, they got it because my son and his wife were stationed there on several occasions. Optic nerves, we talked about already in the eye. They start effectively at the retina. And so, and it's really an extension of the brain when you see it developmentally. They go through the optic canals. Those are in the sphenoid bone. That allows them to crisscross. It's different than the superior orbital fissure, which is more of a straight through kind of a thing, as you will see shortly. So they converge and partially cross over, about 90%, crossover, about 10% do not. That's the so-called stereoscopic or three-dimensional vision that we're so accustomed to. They go, and you remember, without going to the names, lateral geniculate and all that kind of stuff. Okay, they go to the thalamus where they synapse. They basically, in the thalamus, they form a juncture, and then it continues on with something. It starts, it's just called the optic tract to the thalamus. Then it goes to the optic radiation and basically starts its merry journey to figure out what you're seeing in the context of it and something in the visual or occipital cortex. Again, very straightforward, like this. Clinical testing, we use visual fields. You're bringing your hand in from, trying to see when someone can see it. Okay, moving an object or something through it. The fundoscopic exam, that's looking at inside the eye. And again, a lot of these things now are able to do with advanced technology. Like most of you, again, I commented on it before, if you go to the eye doctor, they're able to basically have a device, I'm sure it's extraordinarily expensive, that does all of those things. And they're more than happy to give you bring along a flash drive, and they'll load it with an image of what we call the eye grounds look like. So damaged, blindness in the eye, severed by the nerve, whatever visual pathway, and if it's partial, then we look for where, and that's the idea of understanding the pathway, because you can see kind of, if somebody's losing sight way over here, you're going to be looking way over there, and you can see it's following here. So is there some damage over here on this side? Is there a tumor pushing on it? So now you have a certain degree, and it's all about information, problem solving in medicine, as it is in science and anything, is basically a series of bits of information that you begin to create a picture with. Okay, and then every so often you have, if you're lucky, you have an aha moment. Did you ever used to watch House when it was on a TV show? Like with 5 minutes left to go, he would see something. And, we're having it. My wife thinks it's a House moment. And he has a very, very proper British, when he speaks, he's very, very proper British. And just like Damian Lewis, but they do us really well. And that's what, and for diagnosticians, for people, that's what you look for. When all of a sudden the magical piece came in and made the puzzle visible to you. And so that this is just little bits of information when we look at things diagnostically. And even depending on where you are in the chain, it's at least something that you can say, I'm worried about that. Maybe I should let somebody know, or even let the patient know maybe they should get that checked. Okay. Now those are the pure sensory, everything else is mixed. We did this, that was that LR6 SO43, okay, that you should remember. All of a sudden now we're in the brainstem. And that's significant because if there's damage to the brainstem, that's where your body does homeostasis. So those are big problems. When we see evidence of problems in all of the rest of these cranial nerves, it strongly suggests that there's been damage in some way, shape, or form to the brainstem. Potentially. If it's because there's been a facial fracture, an orbital fracture, okay. That's something you probably can deal with. Okay, because that's something that, it's not something that's going to likely to cause permanent damage, though it might. As opposed to something inside, like a tumor or an infection or something dramatically wrong on the inside, which is going to cause significant problems. And they do all these things. Raise the eyelid. This is moving your finger. All those lateral rectus, medial rectus. Parasympathetic aspect is the idea of being able, when you have light, constricting the pupils. That's effectively glandular. That ciliary body we saw a little bit of in the eye dissection. That is part of what's called the ciliary ganglion. That's parasympathetic. And then the lens, as you remember with those fibers, when it begins to change the shape. When the pupil progresses, there's less fret. When it opens up, there's more stretch, so flattening or rounding out the lens. And you can see it here. That up here is the higher areas. Now we're already there. We're already sitting there, and this is the midbrain region that's there. We're going to the superior orbital fissure, one of many structures that traverse that area. So a lot of nerves go through. That's an important landmark inside the eye. The inferior fissure is really not there. It's filled with cartilage. Nothing goes through. It's one of those neat things that when you get a skeleton and you prep it so you can look at the bones themselves, effectively you boil it. And all that stuff, that cartilage kind of dissolves over time. It's kind of like cooking something long, low, and slow, or if you like me, using an Instant Pot. Instant Pot, it's a pressure cooker. I don't know. We're going away for a couple of days. I may take it with us. Just saying. So you can see it here. This is the ganglion area they're pointing to. And we went over all those 4 of the 6. So eye cannot be moved up or down or inward, because all the lateral, rectus, superior, or oblique are the ones that are not affected. At rest, the eye rotates laterally because inside is not working, so it's being overwhelmed by the lateral rectus pulling it outside. So they call that strabismus. In other words, it's kind of like a variation of cross-eye. Ptosis, typically we pronounce the T, though it should be silent, is that upper droop of an eyelid. You'll see people with that. That's something that's not that uncommon as folks get older. Okay? And a lot of people, when their eyelids droop, that's a relatively common plastic surgery, the blepharoplasty. It's, sort of the eye, you know what I'm talking about? The only one of these nerves that comes dorsally from behind, from the back, from the posterior aspect of the midbrain, or indeed the brainstem, is the trochlear nerve. It's number 4 on the hip parade. So dorsal membrane, superior orbital fissure, as does the last one of these, the abducens, to innervate the superior oblique. Just got one job, primarily motor, and I would agree with that. Again, the sensory is basically, and it contributes to double vision. There's not. Impairs the ability of the eye to rotate, sort of, think of it, they say inferolaterally, sort of downward, being able to kind of look down that way. If you can sort of imagine what I'm doing. That's there. Not a lot to say about that. Pretty straightforward. And the abducens, which I'll go to next just because I always do, because I save time for the trigeminal. The abducens, now we're all the way down to the bottom of the pons. We were just in the midbrain. Pons is enormous comparatively to the brainstem. So you have the giant nerve. There's really 3 nerves in one bundle called the trigeminal. We're going to go back to that. There's a reason. Okay, and then at the bottom, you have this abducens. And after that, you really can't see a whole lot of difference on the sheet, particularly its little threads. So primarily motor, again, lateral rectus for sure. Near nerve, the eye cannot go laterally, so everything kind of goes. It's almost like people are cross-eyed. They're going, would be a reason for that. That's there. Internal strabismus, they call it. And again, the tests are the same. So I skipped a really important one, and I'll go back because it's 3 nerves in one. The largest by diameter because it's 3 nerves in one bundle. Tri for 3. Geminal means ganglia. Those crossover stations where all the cell nuclei are located, okay, sits massively on the pons, as you will see. In the sheep brain dissection, you would have seen evidence of it if the dura, the meningeal covering, was intact. Most of those, because it's less expensive, you just get the brain and the remnants of those nerves. If you had one that had a lot of connective tissue on it and the dura mater on it, then you would have seen that area. You would have seen pituitary and things like that. It's just more expensive, and typically they don't do it in AP1. I get them from my advanced anatomy classes. Okay, ophthalmic, and because it's the 5th cranial nerve, we call them, and everybody uses the same terminology, V1, V2, and V3. The ophthalmic, back to our old friend, the superior orbital fissure, where most of these are mixed. This is mixed too for a variety of reasons, but V1 and V2 are purely sensory, again, with the exception of those proprioceptors. All V1, V2, and V3 are all responsible for facial sensation. And we get a lot of input from our environment facially. So it's a massive amount of information. They're extraordinarily important. They all have the proprioceptors that also act sensory. Where does the motor come from? V3 really has 2 sections. The mandibular nerve, the segment that is motor, innervates your muscles of mastication. If you go back and remember your anatomy, you have 4. You have on each side. You have the temporalis. Think of you chewing, opening and closing your mouth. Temporalis here, masseter here underneath the cheeks, big, powerful chewing muscles, particularly for closing. Gravity opens them. And the side to side, front to back, they're called pterygoids. Because you remember the anatomy, the bottom part of the sphenoid has two projections, and it looks to the old anatomists when they started to describe it of what looked like a pterodactyl, which they called back then. So they're called, they look almost like the wings of called pterygoid. Now we call them pteranodons. For you dinosaur fans, love those. When you have children, you end up with go to the museum, dinosaurs, all that everywhere. See, now that's what I love about being my age. Now my kids are going through that, having to put up with taking the little ones to Disney World. I want that. I want this. We're gonna go, riding around on it's a small word like 3 different times. So I tell my kid, you have to suffer like I suffer. We were down there with my middle one and his family in May, and so thankfully they went to the theme parks without us. My wife and I went to Epcot ourselves. So sensory impulses from various areas of the face that are there, the motor fibers for those muscles of mastication. So the schematic tells you very, very well what it's going to look like. So, I mean, can you do the corneal reflex? Fine, that's part of it. Like a sterile cotton tip over here and somebody start to blink. Or you can, and I don't use pins per se. I take like a sterile needle when I do sensory testing. So it's sterile, very, very thin, like a 25, 27 gauge needle. Higher the number, thinner it is. And you use that, and the hub, the other part of the sterile on the plastic, used for dull. And in neurological hammers, you always have like a little brush and a pin when you take out the bottom of the handle. The good ones do, the expensive ones do. So you can test it that way, and I'll show you the schematic, and I'll get you why it's so important. A word to the wise as you progress through your academic careers. Because I don't know how far along you are, first year, second year, third year, et cetera, et cetera. I know. And what it means is whenever you encounter something that's important to an instructor, professor, teacher, whatever word you want to use. I like instructor because it's very generic. Okay. If they're doing research in a certain area, they're going to ask you a bunch of questions. There'll certainly be a question about it. So I'll get to where it is in shortly. So this is the sensory area. Ophthalmic is typically forehead, and you can see it, of course, maxillary, upper jaw, mandibular, lower jaw, and including all the way around the back. Here are the muscles of mastication. So you can see how elaborate it is. It goes through 3 different openings. Superior orbital fissure for the ophthalmic, as you might guess. You might remember these from anatomy. In the sphenoid bone, it's got a couple of other openings. It's got the foramen rotundum, because it's round, kind of pinpoint. Almost goes straight down into the upper jaw. And the largest of the openings that has a nerve in it, okay, excluding the foramen magnum, is called the foramen ovale. And that's with that very, very large, comparatively mixed nerve that's both mandibular, that's both sensory and motor for muscles of mastication. Here's the imbalance. So why am I telling you this? My wife has this condition, and it's not fun. Trigeminal neuralgia, also known as tic douloureux, which means painful tic. We've never really identified the cause, whether it's a blood vessel pressing on it, whether there's a narrowing, whether there's not enough space. The treatments routinely, even surgically included, are because if you're surgery, you're doing brain surgery, are not particularly useful with regard to that. And when they talk about excruciating, when they call it the painful tic, it's like somebody would go like that, and it would be almost constant. So if you know where, for instance, if you know where Costco is up in Cranberry, it's up on the top of a rise. And it's always windier up there. We got out of the car to go in, and I'm starting to walk from where we parked the car, down at the bottom of the parking lot there. And I'm walking over the side, turn to my side, my wife's not there. She's on the ground. It hit her so hard from the wind gust. Sometimes for a week or two, she couldn't swallow, barely could drink or eat anything. This close to having to drag her unwillingly to the hospital, she was refusing to go to. That kind of bad. this morning, kissed her goodbye became like more of a hug because my teeth are hurting. That's the point. Okay. Usually provoked by some sensory stimulus, brushing teeth, the breeze, as I was telling you about, absolutely true. Loop of artery or vein that compresses the nerve near its exit at the brainstem. Not a lot of room in there. Okay. Fortunately, there is one medication that was an old seizure medication that was used for even for early on for diabetics with that what I was telling you about was called sensory neuropathy, and it's called Tegretol or carbamazepine. That works. You have to take a lot of it, and sometimes difficult to. So she has to take really the maximum dose sometimes. Of late, a little bit less. So it's a really interesting condition. Whether you're likely to see it in somebody. Don't make if somebody has it, that's serious. There's the abducens we already did. Where the trigeminal is sensory, the facial is opposite. It's motor. Now we're all the way down in what's called the pontine medullary junction. For basic, this is the medulla oblongata and the pons. They come out anteriorly, very close to one another. You see the abducens, the facial, a little bit more laterally, and then next to it, that vestibulocochlear, the old auditory nerve that we talked about with the ear. They're all in the same neck of the woods. So, and this one, that's accompanying the vestibulocochlear into the internal acoustic meatus, but it exits through that, what I told you before, right over here, the stylomastoid foramen, right where, if you know when somebody has temporomandibular joint dysfunction, right there. Okay, so it may contribute to it. Facial expression, glandular activity, lacrimal gland, tearing, some salivary gland. So it's very limited what the activity is. It's mostly motor. The sensory function as well as the proprioceptors, you certainly know if your face is doing this, okay, is taste from the anterior 2/3 of the tongue. We looked at that previously. The tongue is sort of like has a facial component and a throat component. The anterior 2/3 is the facial component. Most of our sensations from there. Most of our taste sensation, the salt, sour, sweet, bitter, it predominates in that area. That is there. All this stuff you can read. Okay. Clinic, you can test it with anything, they'll have little strips with these flavors on it. This is the big one. This everybody sees. It's called Bell's palsy. And it can happen as a facial droop. It can happen for no reason. It most frequently accompanies a modest viral infection, a cold, trauma. It could reflect tumor, unknown causes. If there's anything, it can develop rapidly overnight. Herpetic infections, herpes simplex 1, oral herpes, drooping eyelid, mouth sags, tears dripping. And I've seen all of these, or dry eye. I don't know that it may still be treated with steroids. I don't know. Recovery is nearly complete in 70% of the cases. You'll know somebody who has this. One of my mentors had this as a child. So when I met him, he was probably in his 50s or 60s. I think he's still around in his 90s now. And but he had a permanent facial droop. It didn't respond. My brother-in-law at the time, previously, was a 9/11 operator here in the city of Pittsburgh. And that's a tough job because you're getting people, somebody's going to kill me, or I'm going to commit suicide, that type of stuff, terrible stuff that you hear about. And I mean, and he got that, probably the stress. It also contributed to his pretty significant drinking probably at the time. That's there. So all of that, but it did go away. So that's another interesting aside. So here you can see it, where it's coming, roughly where it's coming from. Here, they don't really give you the course as accurately. In classic anatomy, it's divided into these 5 units you don't have to know, whether it's going into the neck or under, the mandibular area, the cheek area, zygomatic, which is cheekbone up here, temporal up here. So there's different divisions and all that stuff, different ganglia that are associated with salivation, things like that. We did the auditory nerve. Other than those tiny motor components to sort of create adaptations, as we talked about, to loud or repetitive or underlying sounds, And we went through all of this, the different kinds of deafness that we covered. And really the last four, we almost look at them as one unit. Three of them go through the same area. So when it comes to testing, it's like, again, for the facial nerve, it's motor. So you can have somebody smile, blink, do that type of stuff. For trigeminal, you do sensory. Glossopharyngeal, other than the taste in the back of your tongue, it's more about swallowing and speaking. The gag reflex is part of that. Those are all really important. Its basic motor functions to help you swallow. You have what are called pharyngeal constrictors, superior, middle, and inferior. That's what allows you to. And these 9, 10, and 11 all have the same passageway that you might have covered in anatomy called the jugular foramen. The jugular foramen has the jugular vein, and with it, at least these three nervous structures. The carotid canal basically just has the carotid artery. And they're close to each other, sort of at the confluence of the under surface area of the occipital bone and the temporal bone. And so they're parasympathetic. Now we're looking at salivary glands again. So there's a lot of salivary glands. So these are the parotid glands. We go over those when we look at digestive. Okay, conduct taste and general sensory impulses from all that area. Very importantly, we're going to get to this in cardiac and in respiratory. These are what are called carotid and aortic bodies and carotid and aortic sinuses. They are pressure and chemical receptors that allow us to adjust our heart rate and our breathing when circumstances dictate. Okay, we control our blood pressure with it to a certain extent. They're super important. It's there. So it's, again, problems with this particular nerve have wide-ranging, because now we're purely in the brainstem. When there's damage here, the prognosis is ominous. If someone has a tumor there in the brainstem, it gets your affairs in order. I hate to put it that way, but that's really what it is. So here you can see it. Here you can see the large of all the salivary glands, the parotid. Inflamed nerve impairs swallowing and taste, as you might guess. So there's ways. It's not that easy to test, but it is in that regard. And here, the only nerve that, and it's really the first one of these that we really named and identified. It's the only nerve that leaves the head and neck area, the vagus. Vagus is short for vagabond. Is how it became named. So it was a vagabond was a wanderer, and so the old anatomists named it for that. They named when you learned all of you learned in muscle about acetylcholine, right? Motor nerves secrete acetylcholine. It makes muscles do a thing. In the old days, they identified that as a secretion coming out of the vagus nerve when they stimulated it, and they called it vagus stuff from the vagus. Just saying. So only one that exits, again, jugular foramen, wide range of parasympathetic fibers. This is the nerve that you should have learned about with autonomic nervous system, all the organs, heart, lungs, digestive, Okay. So a lot of receptors, chemical, pressure, the abdominal organs. This is the taste bud that goes down into the pharynx and epiglottis. The one that we talked about a little bit, like certain hot peppers, you'll feel it sort of down in your throat, like that. Cooking terms, we call that the finish. Use certain peppers for that. Like if you watch like Chopped and things like that, you can see they're all trying to. My presets are ESPN and the Food Network. Sports or cooking. Fair enough. So moving on with this, interestingly, one of the branches of this innervates your larynx. So when someone suffers head trauma and all of a sudden they were speaking fine before and they seem very hoarse, that's a little tell. That suggests that maybe that nerve is impaired because there's no other, it's not like they got struck in the neck, which would be an explanation. So that's one of those little giveaway things that we look at. So laryngeal branches the vagus nerve, all muscles of the larynx, so it can lead to hoarseness or loss of voice and all these other things that are part of it. You can see the wide range. This is a very simple nerve because it only innervates two muscles. We used to call it the spinal accessory nerve. They just shortened it. It's the only cranial nerve that has a spinal component. It gets some branches from C1 through C5 we call rootlets. And what they do is they come up through the cranium for the ramen magnum. They join this nerve, okay, and then they exit by way of the jugular foramen. Sternocleidomastoid, the muscle that lets you do this, this, and this, and the trapezius. So put your hand on somebody's shoulders and say, shrug them. Put your hand on their head and say, move it. Muscles are strong. They can move against resistance. There's a whole thing with muscle testing and muscle grading that we teach more with folks who are doing physical therapy and orthopedics. If that's where you're heading in some type of a thing, then you'll learn more about, you grade muscles like 1 through 5 or 1 through 6, depending on what you do. And being able to move them against resistance means that your muscles are strong. So that's the 11th. And then here's the course, here are the rootlets, here it's coming up, then it's going back down. And then lastly, easiest of them all, the hypoglossal canals on either side of the foramen magnum and the occipital bone. And interestingly, the accessory nerve, to some extent the vagus nerve and the hypoglossal nerve, where most of the time when something's damaged, it's on the other side. Most fibers cross over. A lot of these cranial nerves, it's same side. So when and this is the one that sticks out your tongue. Hypoglossal means under the tongue. And it's really as pure motor with that tiny bit of sensory, because if your tongue's sticking out. But when you tell somebody to stick out their tongue, it goes out straight. Stick out your tongue. Okay. Now, if somebody does that, you say, hey, I told you to stick it out straight. They go, it is straight. There's usually damage on that side. It's the same thing with the shoulders, the same-sided problems that are there. We see this, it's an old terminology. When you see someone who's getting close to dying in the hospital and they're in bad shape, all of a sudden you'll see them in bed like that. We call it O sign. And when it gets worse, Q sign, depending on what side. Left Q. True. So those are the kinds of things. And for every time my 97-year-old mother-in-law, she's trying to watch the game, and it's like all of a sudden it's like. So there you go. And that's everything from that. And the same stuff that you saw before. It's fairly straightforward, I think, for most of these things. And I don't even. What are you talking about with that? Sensory motor or both? Yeah. Isn't that easier than this nonsense? It's crazy. Yeah. Sensory, motor, or both. And frequently both. Which brings us to the spinal nerves. We should be able to get through these fairly straightforwardly. Spinal nerves are not exactly the same number as there are cervical vertebrae, and that's where the difference is now. So it's not necessarily the same as the bone. There are 7 cervical vertebrae. We typically number the nerve for the vertebrae it goes out under. The only one that has one that's going out on top is the cervical unit. So they're named number 1, C1 as we call it, goes out above the first cervical vertebrae, underlying the foramen magnum, the occipital bone. C2 underneath that vertebrae, and so on. So that for 7 vertebrae, that's how we get 8. After that, all the thoracic is under that numbered thoracic vertebrae. Same with lumbar. Sacral are hard to distinguish because they're in the sacrum, but they're effectively 4 or 5 fused bones in the sacrum. And even though there's usually 2 or 3 bones that make up the coccyx, there's really only one tiny, rather vestigial nerve. So you have 31 here. You actually have probably proportionately, if you added up, more bones. It's not a big deal. So each of the 7 pairs, C1 through 7, happens to exit above, and that's that intervertebral canal. The spinal cord is going through the vertebral canal, that stack of foramina that are being kept open by the discs on the side, and the discs are doing the same thing. And you probably saw that in anatomy. So when a disc slips, it creates an irregularity, and that opening can get pinched. That's what a pinched nerve ends up. Typically, it's more of a disc-related problem or an arthritic problem that are part of it. So the last spinal nerve exits inferior to C7, so vertebra C7 is a nerve that leads above it. and one that leads below it. For that matter, so does the first one. So each of the other spinal nerves is inferior. So the cervical or the oddball. That's about all you have to know with that. And you've probably seen this before when you first did central nervous system. The interesting part about that are certain things that are here. We see an enlargement here in the cervical area. And that area is responsible principally for upper extremity activity. So it will lead to what's called a plexus. So you have both the cervical plexus, smaller, not unimportant, and the brachial plexus, considerably important. Okay, you have a lumbar enlargement. We used to call lumbar sacral. And indeed, we call this plexus lumbar sacral. Now we separate them anatomically. In the thoracic area, most of these nerves do not undergo this unique crossing over that we call a plexus, and I'll show it to you. They just go to the rib or the related tissue either above or below or between the ribs. So the spinal nerves, ventral is motor by definition, dorsal is sensory, so efferent and afferent. They branch, and what we see is that it's not like one unique nerve. It's not like a cord coming out here. It's that series of rootlets, tiny little pieces coming out to form one. And that's why we get a lot of interesting contributions. So when there's damage, it isn't always consistent. A pinched nerve might cause pain in one area, numbness in another. It might cause limited mobility in some or no mobility in some. It all depends. So it depends on which one of those rootlets is impacted. And then what happens afterwards that are there. There are the rootlets. And you actually see this. I used to have, I don't know if I told you or not, when I was teaching over at Chatham about 20 years ago, I was doing a anatomy for the doctor of physical therapy and at that time the masters of occupational therapy students. I was doing the lab component. And the lead professor was a lead neurologist at Pitt. Okay. Hold on, real quick. And so he actually had access to a human spinal cord and brain that was just buried in formaldehyde. So it was all a big bucket and just horrible smell. So I demonstrated to students in that. And it's just a great story because at that time, I think my daughter was about 18, now 37. And I was taking it to show some of the other class. I was part-time teaching. And in the back of she opened the trunk to get, you got a human brain in your car? I said, yes. He goes, oh, can my friends see it? That's why my kids are strange, because they had to grow up with a strange father. I can just imagine. Oh, Dad's got a brain in a car. Oh, what's new about that? I always thought I was some, we won't even go there. So you don't have to know all this stuff. Okay? This is called the sympathetic chain. It's a unique chain we only really see in the thoracic and lumbar area. That because the sympathetic nervous system is from those two areas where the parasympathetic, you might remember, is from the cranial nerves and the sacral nerves. So they're very much different. And even though they supply many, many similar organs, but anatomically they're different. And this is that dorsal root ganglia, where all the sensory nerves kind of come in and cluster. And you can see it's right in that area, the intervertebral canal. So that can be affected adversely, again, by spinal dysfunctions, arthritis, slip discs, whatever you want to call them, that are there. But this is a pretty good picture. And then these little, what are called rami. So even though they bundle together, you have little branches going to like the erector spinae muscles that are back there. You're basically surrounding the spine that keep your back erect and things like that. So there's a lot to it that's there. These are the rami, one branch to the meninges, ones that communicate. I don't go crazy over this stuff. That's what I mean. These are like the paraspinal muscles. They're so important for our posture that are there. And so you can go crazy with this stuff. And again, I do it more in the advanced anatomy, which I'll be doing it this term with them. But the roots themselves are either sensory or motor. When they join together, now you begin to see the branching. So all of those rami, except T2 through T12, interlace. They cross over. It's like a giant roadway where multiple roads are coming together, and you can. I see it in Orlando when we vacation there. You got the Florida Turnpike, you have I-95, you have I-4, 6,000 other roads, all of which are toll roads, and you're constantly going around. So that's what you'll see with these, and I'll show them to you. Basically, there's a key nerve, or 2, 3, and as many as 5 in each of these plexes, and these are the ones you need to know. The first 4, okay, ventral rami, and sometimes a little bit of 5, okay, form this cervical plexus. And you can see it supplies these areas here and here, neck muscles. The key player here is the phrenic nerve, and it tells you right away what it supplies. That PHR only has one place anatomically, and that's the diaphragm. Why is that important? When somebody, it's the thing we worry about the most when somebody breaks their neck, particularly an equestric fall from a horse. They typically break their neck somewhere around C3 or C4. The biggest problem with them, not even talking about quadriplegia or paraplegia, the biggest problem that you worry about, life-threatening, is respiratory. When those folks succumb, they typically succumb to respiratory problems because it paralyzes their diaphragm. Classic example of a famous actor who died after a fall from a horse was Christopher Reeve, who played the original, not TV, but movie Superman in 1979. Who was, again, was a very, very proper actor, very handsome guy, who always had to lose a ton of weight to do the role. It wasn't like the guy, Henry Clavell, the one who played it recently. He's the Witcher. You don't watch TV. Awful. I know you're busy. Yeah, I don't have nearly as much time in your hands as I do. Nevertheless, what happens, that's what you worry about. And so he, even though he regained a tiny amount of motion from quadriplegia in his fingers, eventually he succumbed to respiratory failure, which is very, very tragic. He's a very, very popular character who really thrived on serious roles, but I'm sure the Superman thing paid bills. So here's what it is, and here's that big branch coming down. That's the phrenic. That's the one you have to know from the cervical plexus. And it innervates the diaphragm. And all these other ones, not terribly relevant for us. So hiccups, irritation of that particular nerve. And again, when we see the severance of it, that's when we start to end up people on respirators. Are they going to, is it going to return, etc. The one that has the most, final nerves that come out is called the brachial plexus. In classic anatomy, in medical school anatomy, you have to learn all of these. Roots, trunks, divisions, chords, and branches. It's RTDCB. We made a mnemonic out of that, a little saying, so we could remember that, and we learned about all of them. You don't. I just want you to know what ends up. This is the complexity of it. C4 through T1, a lot of these branches, and they cross over. What effectively comes out are 5 nerves that are relevant, okay? And you can see the color-coded. Anterior, and in the upper extremity, anterior is the flexor surface, posterior is the extensor surface. It's reversed in the lower extremity, where the extensor surface is anterior and the big calf and hamstring muscles are flexor muscles. There. So all you have to know is what ends up. And so there's only 2 nerves from the posterior division that are really relevant to us, okay? The axillary nerve and the big muscle that innervates is the deltoid. So if you do this, you're not doing the chicken dance. Really? Dollar dance? Oh, come on. There are no Yinzers among you? Why does the Jewish kid from New Jersey know this? My first wife from Stanton Heights, my current wife's from Bellevue. They're in touch with their inner yinzer. They have water-containing vessels on the walls, pitchers. See, you got that. You know somebody who says that. They're redding up things. We said soda, you guys say pop. Just pointing out. I didn't offend you, did I? I apologize. So, look, I'm a dyed-in-the-wool Steeler fan. I live, breathe, and die Steelers. Moving along. So it does this. That the deltoids have massive muscle where you give injections here, and it's mostly lateral and posterior. So that's the way you test it. The other one is the radial nerve. Nearly every other structure on the extensor area, from straightening out your fingers, straightening out your elbow, straightening out your arm, all of those are the radial nerve. Very, very large area that it covers. Anteriorly, you have three. You have the musculocutaneous. It's the big deal in your arm. Biceps brachii and the other massive muscle underneath it, brachialis. Then you have two. You have the ulnar nerve, funny bone, mostly structures on the ulnar aspect, sensation going down into your pinky and about this half of your ring finger. And everything else is from the nerve that's associated with carpal tunnel. That's the median nerve. Surgeons call that mother median when they do hand surgeons. It's the one where you can tap on it if someone has carpal tunnel. A lot of people have it over time. Okay. And it's why they redesigned, computers, because we rest ourselves. In the old days, you used to rest your hand on the steering wheel like that. So truck drivers had that type of a thing. People drove all that. So it's real, and I have it. I get little jolts like that, not painful, but have some degree of that's the median nerve. That's nearly every muscle that comes flexor in and around the arm, even in the wrist, moving it this way and that way, that type of thing. You'll see. So those are the nerves into musculocutaneous, median, and ulnar. Okay, they're all the anterior flexor, radial and axillary are the posterior or extensor. Axillary deltoid, skin around the shoulder, teres minor, part of the rotator cuff, musculocutaneous, biceps brachii, brachialis, skin of the lateral forearm, so it's over here. Okay. Median skin, most flexors, forearm pronators, wrist and finger flexors, opposing the thumb. Big player. We had a guy when I was a resident, some kid slashed his wrists. And I was on call in the OR, and they put out a call if we had a hand surgeon, not one on staff, one came from a neighboring hospital a couple blocks away. And the first thing we got there, and I'm insisting, no idea how to do it, just holding the retractor. And he goes, I've got to find mother median. It's intact. Okay, we're okay. Like that. See, I learned, and I'm like a sponge trying to learn all that stuff. The ulnar, flexor carpi ulnaris, brings it this way. Flexor digitorum profundus, so it can give your fingers a little bit of that. Most of the intrinsic muscles here, skin on the medial aspect of the hand, some wrist and finger flexion more on the ulnar aspect or medial aspect. Radial enumerates essentially all extensor muscles, supinators, posterior skin. So it tells, and this is the schematic that shows it to you. We don't have to go into it. So you only have two more plexes to be troubled by here. My middle one keeps texting me. He's doing online training for a job, and it's got like 2 weeks worth of these tests that you have to do the modules and do the tests, do the modules. It's driving him crazy. This son and my daughter have never been inside other than for parties, college. Went to, hey, Dad, I'm going to be at RMU. I said, are you going to take courses? She said, no, I'm dating a girl. She wants me to come to class with her. It was a night class. This is about 7 years ago or so. Great, you're finally in college. Go figure. So here are all those structures. Now, here's a big one, brachial plexus. Okay, upper limb, pull it too hard. We see a lot of these when you with arm tackling, blows to the shoulder. The one you see the most is very interesting. Okay, with a crutch. If you've ever been on crutches, how do they tell you where to put the crutches? People who are lazy put them in here in the axilla. What happens? You can get a nerve palsy, meaning you can traumatize the nerve and you'll weaken it significantly. There's design, if the crutches are dealt with properly, if you're going to physical therapy to learn all this, to be here against your chest wall. That's where you have it. You pad it so it can stay. So when you're standing and you're using the crutches basically to balance on, they should be here, not so. And there's other little tricks of the trade like that for the lower extremity as well. There's all sorts of those, and it's based on the anatomy, where the nerves are. So when you have nerves that are close to the surface, you have to be cautious with regard to them. Median nerve, like that, that's carpal tunnel. Again, this is what I was telling you about with that suicide. We saw a couple of those. It wasn't that unusual back then. And this is, I was a resident when I saw this 46 years ago, Philadelphia. Ulnar nerve, you all know about that. Damage the ulnar nerve. There's a lot of things, but typically most of us, it's just incidental trauma when we hit our funny bone. Okay, that's really what it is. I mean, it can become, as you can see, more severe because the nerve is right against that epicondyle that's kind of large on the medial aspect, if you remember your humeral anatomy. And that's why they the humerus, and they named it funny bone, like humerus spelled like humor. And again, radial nerve, wrist drop because you can't extend. Okay. So here's the crutch use one I was telling you about. Intoxicated person, falls with their arm like this. Most of us, when we do that, our arm falls asleep, quote unquote. And those come back pretty fast. When they don't, then you have to suspect there's a greater amount of damage. It's nice seeing you again. We used to consider this as one. Now we look at two. The lumbar, when you think of the lower extremity, it's compartmentalized. In the thigh, you have three compartments: anterior, medial, posterior. Okay. In the leg, somewhat like that as well. You have the largest is posterior, your calf is. But you have an anterolateral group, which helps you bring your toes towards your nose, and you have a lateral group, which sort of stabilizes on the outside. So each of those compartments have different nervous innervation. That's sort of the background behind this that are there. So we don't consider them as one, but we now we separate them. So lower limb branches, the abdomen, pelvis, buttocks, all of that are part of it. So now the lumbar, L1 to L4. Why is this important when you're testing somebody's knee jerk reflex? That tests roughly L2, L3, and L4. So there's a reason when we test reflexes. It's a quick way to see, like for somebody like me who has a chiropractor twice, every other week, I get a bad back. So it innervates thigh, abdominal wall. The psoas, you might remember, is the big muscle that allows you to do this. So that's the muscle that's sort of adjacent to your spine, comes down through the exits through the obturator foramen, if you remember where that is, in the iliac bone, and inserts into the lesser trochanter. So what's there? The femoral nerve, very important. That's the one about the knee jerk. The quadriceps, there are four muscles. Skin of the anterior thigh extends with a branch called the saphenous or saphenous nerve all the way down to the medial aspect of your leg, right in front of the medial malleolus. And then a big player through the obturator foramen, the obturator nerve, that's the adductor muscles, groin muscles. So when you hear anatomically someone has a groin pull or has damaged that nerve, it's really difficult. We see that a lot in sport. So there's a lot of other nerves that come off of this, but the big players here are obturator and femoral. When you talk about so here you can see it. The femoral nerve is different. They don't go through the same opening. The obturator nerve, just like I was telling you about the psoas or iliopsoas muscle, comes through the obturator frame, and that's that opening here. You can see it on that side, and carries all the way down here into those adductor muscles, the most of them. And here's the continuation, the saphenous or saphenous nerve, all the way down anterior to this, which is the medial malleolus. And then going through the inguinal ligament area. So when you hear somebody with a problem when they talk about a sports hernia or a rupture, that's all the inguinal ligament. That area, and it can happen in both men and women, though it's more frequent in men. That's that sort of piece of tissue that goes from here, the anterior superior iliac spine, to the symphysis pubis over here. And there's a series of tunnels for the femoral nerve, femoral artery, femoral vein, and other structures that are there. In men, that's where the spermatic cord goes into the scrotum. So it's, again, that's why we see it more frequently in men than in women. Again, it can be in both. So the one who's texting me now, the same one who hasn't been to college. Okay. So he was working in heavy industry, ended up having to get a double hernia repair. Okay. When he was in his mid-20s, he's 39. So that's a really critical area. That's an area when we can't find a vein, let's say in a drug addict to start an IV line, we do a thing called a cut down in that area. So you access, and it's an access point for those of you in imaging when they're starting to do scans. That's another area where you can introduce for you. It's another line that you can put in, and we used to put it in for cardiac catheterization through that same area, and other things that were there. So, and it gives you an idea what they're supplying, but those are the two biggies. And then the sacral plexus, again, it used to be all one, L4, and there's always some overlap to S4, buttocks, lower limb, particularly the posterior compartments. And the big player in this is a nerve, just like the vestibulocochlear. This is two nerves wrapped in one. We call it the sciatic. Okay, in the old days, they called it the ischiatic because it was by the ischium. Innervates the longest and thickest nerve by far, innervates the hamstrings. Okay. The adductor magnus, the largest of all these adductors, most of the muscles in the leg and the foot, has the tibial nerve and what's called the common fibular nerve. So those are the two components that are there. So the tibial nerve eventually, as it goes, as you'll see what happens, as it goes behind the knee, it begins to branch out to a certain, and effectively what it does, it gives a branch to the calf called the sural nerve, and eventually to the foot, the nerves, and most of the muscles and most of the structures or the sensation is bottom of the foot, medial and lateral plantar nerves. The common fibular used to be called the common peroneal. It's a confusing term why they changed it, because perineal, P-E-R-I-N-E-L, is the anal genital area. Innervates the knee, skin of the legs, muscles of the legs, and you have ones that go to the buttocks area, one that goes into the perineum, as you can see, the P-U-R-I aspect of it. Here, look at how big this is. Common fibular and tibial. Massive. There's that sciatic notch that you might remember from anatomy. That's there. And as you can see, here it is going down. And basically, it goes straight down behind the femur. And in the popliteal fossa, it divides. So now you have the tibial nerve going down all the way eventually into the foot. The common fibular, whenever you see common, it always means you're going to branch out again. So it gives off the deep and superficial fibular nerves, which each supply different areas. The superficial fibular nerve actually goes somewhat more distant and goes more to the top of the foot, and the superficial goes more to the exterior of the foot. So we begin to see them associated with things like foot drop. Okay, more on that in a second. Here's what it looks like anatomically. Gives you all of these different ways that it goes. Summarizes it. So if they're compressed, walking problems, pain and numbness, prime femoral plays a big role in sort of lifting your labia, and again, herniated discs, pain in the medial thigh. Very common. We give it a generic name, sciatica, for inflammation of that. It could be anywhere. Okay, from a disc, and that's why we don't give injections into the gluteus maximus, into the buttock area. You give injections into the gluteus medius, which is more upper hip, because it's too easy if you don't know what you're doing to nail that sciatic nerve. Sometimes you have certain injections, so you have to know what you're doing with regard to that. And so we do see foot drop, but we see it from more than anything else is a misplaced cast. Now there's a lot less casts that are done today than they used to be. Okay, now because we have how many students do we see on the campus in those plastic sort of sandwich braces taking the place? And what's nice about that is you can take them off and do wound care, physical therapy, skin care, all that. So they're advantageous. We always had casts. And casts are either short leg or long leg. And when you have a long leg, you always have the knee flexed X amount of degrees, usually back body, to avoid compressing the nerve. The big problem with short leg casts is here. That perineal nerve, or fibular nerve, runs around the neck of the fibula, right here. So anatomically, we palpate the head of the fibula, 2 finger breadths, and the cast goes to put on it. In the old days, we used plaster. Then we started using a lot of fiberglass. I did both. As a resident, we did only plastic pads, no gloves. Thank you. It was the rite of passage. Your hands would come out looking white with plaster on them. And then after that, we used fiberglass, which is a lot easier and came in very attractive colors. I want a blue can. I want a pink can. So all those types of things that are there. And so this is an interesting chart that kind of brings it together. These are called dermatomes that are there. Okay. And this is where we use when you're testing sensation, this is how you know. So here, knee jerk, L3, L4, probably a little bit of L2. Achilles tendon, when you tap that and the foot will plantar flex, you get a little bit of L5, S1, and S2 are basically involved there. So that's how you can kind of get an idea. And usually there's a fair amount of overlap. Okay. Any nerve serving a muscle that produces movement at a joint also innervates that joint. And that's everything. So I will see everybody at 2. We'll take a look at this technology, maybe a little more amplification of nerves and where we're going, and maybe take an hour in lab, and then au revoir.